country. And sometimes we use synonyms like ART or HAART or combination ART or a fixed dose ART. So these are all some synonyms that we keep using, but everything means that you are giving drugs in a combination. You're not giving single molecule. Like for example, you just don't give zidovudine, but you give a combination of drugs in the form of a single combination pill. Now, this slide depicts what the antiretroviral benefits are for a person living with HIV if taken properly. That is, you definitely have a continued viral suppression or reduced viral load, increased CD4 count, and your disease transmission or progression decreases, and your frequency of getting opportunistic infections also is slashed down by more than half. Now, for any therapy that we have, take it diabetes, take it hypertension, ART also has certain goals. So there are 5 goals that we usually talk about whenever we start talking of antiretroviral therapy. The first thing that we have are the clinical goals. That is, if I take the drugs properly, I will survive for long and will have a good quality of life like any normal person in the current circumstance. Virological goals are you want to suppress the viral load in the body so that you don't transmit to others, that is to the community. And number one, you yourself get healthy. That is a virological goal. And then immunological goals, you see that there is a quantitative and a qualitative increase in the CD4 cell count as a person is on antiretroviral therapy. Now, therapeutic goals, this is very important. I want everybody to listen to this therapeutic goal. Now, why we are worried so much about why a patient should be monitored very carefully, why every second line, any substitution or switch needs to be monitored is we do not, we as a prescriber, as a medical officer starting ART to a patient, I need to understand, suppose I fail this therapy, what is that next therapy available for me? That is called a sequencing of drugs. So we need to understand how to rationalize sequencing of drugs for an individual patient. If I fail on regimen X, what is going to be my next? So that is the reason why we say that we need to have a therapeutic goal in mind whenever we start initiating a person on antiretroviral therapy, and we also need to ensure that the patient continues the therapy for long without much adverse events of those drugs. A preventive goal, this is very important. These days we call this as treatment as prevention, or TASP. This mainly talks about if a community, if you have 100 people, for example, and everybody starts taking ART and everybody's viral load is undetectable, you do not transmit. So this is the preventive goal. That is, you cannot transmit your infection to other person even with an undetectable viral load. This is called as U is equal to U, what you see in most of the literature these days. So with this, we go into the mechanism of action of antiretroviral drugs. As you all know, the virus is made up of a glycoprotein layer, and then you have core proteins or the core nucleic acids as part of the viral genome. Now, the antiretroviral drugs are blocking different steps of this viral replication. For example, you see a fusion inhibitor, that will not allow the viral particle or the CD4 cell receptor to even to fuse with the envelope. So that is called as a fusion inhibitors. And the drug that we have currently is enfuvirtide. Then the other group is, for every HIV virus to enter into the human cell, you need to have CD4 receptors. Now, when the receptor of CD4 cell and the viral particle tries to fuse with each other, there are certain co-receptors. They are CXCR4 and CCR5 co-receptors we have. So if we inhibit these co-receptors, then there is no fusion. This conformational change will not happen when the viral particle or comes in contact with the CD4 cell. So this conformational change is very required for the virus to enter into the human cell. In the absence of a co-receptor, this is not going to happen. So CXCR4 and CCR5 are the co-receptors which enable this conformational change in the HIV virus. Sorry, this conformational change so that the virus is not getting into the CD4 cell. Suppose the virus penetrates and you do not have fusion inhibitors, you do not have CXCR4 receptors inhibitors, but the virus has entered into the CD4 cell. So what happens, the next level of mechanism or the drugs that we have is a very important step where a HIV RNA is becoming into a HIV DNA. There is an enzyme called as a reverse transcriptase. So you have two types of inhibitors there. That is the drugs which inhibit the reverse transcription. So these are all NRTA group of drugs or NNRTA group of drugs we have here. So if you see in the bottom lower bottom of the picture in front of you, you have NRTs, nucleoside reverse transcriptase inhibitors. You have AZT3TC, stavudine, and abacavir. And then NTRTI is nothing but nucleotide, that is nucleoside NRTI. And NNRTI is non-nucleoside reverse transcriptase inhibitors. And we have only two drugs within the national program, that is nevirapine and efavirenz. So the not visible. Okay. So and then once they go into, suppose the viral has escaped even this reverse transcriptase, I will again share it otherwise. I'll again share, yeah.
It's visible now, sir.
Yeah, yeah. So now the first steps we have seen fusion inhibitors, then we have seen reverse transcriptase, then we have seen CXCR4 or inhibitors. Now let us co-receptor inhibitors. Now let us see what happens if you skip this step of reverse transcriptase. Then what happens is the HIV viral DNA integrates with the human host genome. So at this point of time, there needs to be an integration of this HIV DNA into the human genome. So at this point of time, you have certain inhibitors called as inhibitors. And what today the DTG drug what we are using belongs to this group here, that is integrase inhibitors. And suppose this step is missed out, then what happens is after integration there is a transcription into an mRNA. There you need some proteins to cleave the virus to form into a smaller viral particles or genome. At this point of time, you have protease inhibitors. And then last is the budding stage. So at each critical step of the life cycle of HIV virus, you have different drugs that target at each of these critical steps. It starts with fusion inhibitors, then a co-receptor inhibitors, reverse transcriptases, integrase, protease inhibitors. So these are all the group of drugs that we have. And there are certain other drugs that also help to enhance these other drugs at the same point of time. So why I'm taking some time to explain you all this is, when we give a group of drug, you need to understand what are we targeting in this patient. For example, if I say, you can start writing in your chat box, okay? Question number one. Now, suppose a patient is given a drug called as TLD, tenofovir, lamivudine, and DTG or dolutegravir. So, where are these drugs going to act on the HIV virus? You have to just write in the chat box saying reverse transcriptase or both reverse transcriptase and integrase inhibitor, or it is going to act on fusion inhibition. So what is that? You just start putting in your chat boxes. I'll just give another half a minute. Yeah, Dr. Anne Joseph has written. Anybody else? Okay. Good. Another last 10 seconds. Yeah, very good. Surya Pratibha Garu, reverse transcriptase and integrase inhibitors. Good. So now you understand why we give so much importance into knowing which are the group of drugs we are looking at and what are we giving to our patients. So now what you see is the different classes of antiretroviral drugs we have. And if you see in your national guidelines, we have also given an asterisk that you see at the bottom of the slide saying that these are available within the national program. And you also had a session last week or prior to this week, prior to last, on what are the different groups of drugs that are phased out in the national program and what we are having today. So within the program in nucleoside reverse transcriptase, we have zidovudine, lamivudine, and primarily abacavir. And to NNRTI, we have nevirapine, efavirenz. In protease inhibitors, we have ritonavir, lopinavir, itazanavir, darunavir, and then dolutegravir we have. So my next question, okay? So all of you um, have to tell me darunavir belongs to which group of drugs? Is it a PI or is it a NRTI or is it a fusion inhibitor? Darunavir. Another 30 seconds we'll spend on this. Darunavir. Darunavir belongs to which class of drugs? Darunavir. Yes. So this is another common error that we do. Darunavir and dolutegravir. So dolutegravir is actually a fusion inhibitor. Darunavir is a protease inhibitor. Now, why I'm again telling this is another common mistake what we do while prescribing antiretroviral therapy for whoever are on third line. Usually, we give darunavir and dolutegravir. So, some of your medical officers have called me and asked me, sir, why is this prescription giving two fusion inhibitors? So, it's not two fusion inhibitors; they are put on one PI, which is darunavir. Dolutegravir is a fusion inhibitor. And to confuse you more, if somebody asks you what is didenosine, again, this starts with D. Didenosine is phased out, but that again is a NRTA group of drugs. So, and everybody, I encourage you all to know the full forms of each drugs. For example, if I ask you what is um, TLD, everybody knows it is TLD, TLD. But what does T stand for in TLD? T in TLD stands for, you can use a chat box. Tenofovir, right? Yeah. So, and there are many forms of tenofovir, as you know. You know that there is tenofovir. TDF is the complete name of tenofovir, what we have. Now, within market, you have another drug called as TAF. So, you need to know the entire name of this because you just work on 10 or 12 molecules. At least we have to understand the complete name of that. Tenofovir diproxyl fumarate is TDF we are talking about. AZT is azidothiamidine that we are giving, 3TC. So, and very importantly, you have to also know these short forms. I'll just give you one example. Why is it important? For example, AZT, 3TC, D4T. These are three groups talk about, they have common T, 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 T. These are all called as thymidine analogs. So when we talk about the thymidine analog, then you have to remember, okay, we have three drugs, that is AZT3TC and D4T. Even TDF has, even tenofovir has TDF, but that T is different from the AZT3TC and D40 that we are talking. So this is very, very important. Don't take this very lightly in terms of knowing the names, because your further therapy, as you have seen, the goal of antiretroviral therapy, you have to know how to sequence. For sequencing, you should know all these things. Okay, good. People are attentive. After knowing what are the drugs, so here as I go through, you can see, for example, tenofovir. Why is tenofovir not just given as T but TDF? TDF means it is tenofovir disoproxil fumarate. And most common side effects, you know that it is renal toxicity. Whenever you talk of zidovudine, you have to you have to know group toxicities. So another very important thing is you have to know the group toxicities first. For example, NRTA group of drugs. From that group of drug, most of these drugs will cause you hypersensitivity, and most commonly zidovudine will cause you more of bone marrow depression and anemia. Lamivudine is usually a safer drug with a very minimal toxicity in the form of rash. Abacavir has again hypersensitivity as its most common side effect. And everybody has to remember, usually we do not challenge abacavir after a reaction. Some of your medical officers, in your experience, you would have seen some patients coming with a nevirapine rash. And after some time, again, you would have given nevirapine to that same patient. But in abacavir toxicity, if somebody is coming with with an abacavir rash, you do not again re-challenge abacavir in that patient. So that is the difference between a hypersensitivity reaction from abacavir compared to an NRTA group of drugs. Just remember that. And then efavirenz, everybody should be remembering one important side effect for this is the neuro hallucinations, or the central nervous system side effects are mostly seen in efavirenz and rash. Nevirapine is also rash, and both these drugs usually cause hepatotoxicity. Okay, they have hypersensitivity reaction, and only efavirenz has a central nervous system symptoms. So these are the common NNRTA related sort of side effects. And mostly our discussion, we will talk more on dolutegravir, and in several other discussions also we had mostly of this. But now we know dolutegravir is the first line of is part of the first line of treatment, DTG, and it is also called as INSTI, integrase inhibitors. Okay, and then this has activity against both HIV-1 and HIV-2. Earlier, we were not giving NNRTIs for a patient who has HIV-2. That is the reason we are bringing back and saying that this drug is effective both in patients with both HIV-1 and 2, or only HIV-2 and HIV-1. So any HIV, doesn't matter of which group it belongs to, it is going to act on everybody. So if you see dolutegravir, it is the first line of management within the national program. Now we have two drugs, integrase inhibitors. One is dolutegravir and the other is raltegravir. And raltegravir mostly is used as one of the options in second or third line management. Earlier we were using as the preferred third line management. And then we have substituted them in between. We have transitioned most of those patients on raltegravir to dolutegravir. And the side effects that you have seen are very minimal side effects. And insomnia and headache are most frequent among those limited side effects that we see. There is a weight gain noted, and there is also some reports of hyperglycemia that are reported, and we are yet to see what is how much is that within our population in India. But there are certain reports that have come out that there is an increased hyperglycemia or diabetes mellitus, frankly, coming in patients who are on dolutegravir based regimen. And raltegravir, as you see, is now not much used as a first line or a preferred third line. It is given in the form of whenever you do not have options for dolutegravir, then we bring in this. Now, key drug-drug interactions between dolutegravir. For example, if you're using amlodipine or carbamazepine or phenobarbital or phenytoin, usually these have to be used with caution, or you can even withhold them using along with dolutegravir, and other alternative anti-malarial or an anticonvulsants need to be given. But again, if you are using carbamazepine, use DTG twice daily or substitute with any other. So you need to increase the dose of dolutegravir whenever we use along with carbamazepine. And very other important common error that we again look at is whenever we give it with metformin, very important, whenever we give dolutegravir with metformin, we need to limit the daily dose of metformin to 100 milligrams and monitor the glycemic control. Okay, you cannot give more of metformin whenever you are using dolutegravir. So that is one other limitation that we need to give, or put the patient on an alternate anti-glycemic drug. Sorry, the last one I missed. And rifampicin, we need to double the dose. That's why whenever we have a patient who is on dolutegravir based regimen, we give them double the dose of dolutegravir. One in the evening, additional dose 50 milligrams we give until after completion of ATT, and we wait for 2 weeks and then start the monotherapy. I mean, we do not immediately switch it. So these are some of the things I will not go because these were in the program since long, and most of you have know these side effects. Now, before starting a patient on antiretroviral therapy, what are those that you need to consider? The patient must be adequately prepared. Now we are talking of something called as a rapid ART initiation. A rapid ART initiation means when a patient is coming to the ART center on the day of registration, we try to ensure that the patient is assessed for his preparedness, that he knows that ART should be taken lifelong. And we need to identify a caregiver to support him for his lifelong antiretroviral therapy, his or her antiretroviral therapy. And we need to do a thorough clinical examination with the staging of the patient. And we need to reassess whether for tuberculosis, whether the patient has TB, doesn't have TB, and OI treatment should be initiated. And for prevention of OIs. Now, before we start the clinical picture, we have categorized into certain opportunistic infections that we identify before starting ART, or if they are coming with a generalized fever, for example, an undiagnosed active infection with fever. We need to diagnose it, treat first, and then start ART. So again, a rule of thumb, always treat the opportunistic infection and then start ART. That is a rule of thumb that we follow here. But for certain opportunistic infections like pleuritic papillary eruptions, PPE, or like a central nervous system ones like the PMLE, all these OIs will definitely require ART as a mainstay of treatment for them. But in general, usually we follow a rule wherein we treat the OI first and then start the antiretroviral therapy. For example, PCP, we treat PCP and then start. Tuberculosis also, what we say is within 2 weeks, we initiate first ATT. Within 2 weeks, we try to start the treatment for tuberculosis. Bacterial pneumonia. So anything, first rule of thumb is start OI management and then take care of ART. Now, if you see, initially we started our national program saying that we start ART to patients only who have a CD4 count less than 200. And then we had very good trials, CIPRA and the SMART studies, which have demonstrated that starting ART in less than 350 cells will have a higher impact on reducing mortality and longevity. Later, there were observed studies that even if we have greater than 350 cells, there is an impact on disease progression. And lastly, now we have the START and the Temperon study where we are starting ART, irrespective of irrespective of the CD4 of the patient. This is the treat all era we are in since 2017. We have been following and we are giving ART to all patients who are diagnosed HIV, irrespective of their CD4 count and WHO clinical staging. Irrespective of anything, we are starting antiretroviral therapy. And the main important thing that we need to understand is starting treatment is not an emergency, but to ensure and make sure that the patient is thoroughly screened clinically with a past history, with the family history, contact history, everything taken together. Identifying a treatment supporter with good adherence will give much better results to for the patient to stay lifelong on antiretroviral therapy. So, what to start? And FDC, I already told you FDC is a fixed dose combination that we use, that is adding more than one or two molecules, more than one molecule to make a fixed dose combination. Fixed dose combination, not just for ART we have. Now we are also having for ATT a fixed dose combination. Earlier we had a pouches for TB treatment. Now we have again a fixed dose combinations of all our ATT drugs packed together. So the advantages of that, it is easy to prescribe for the patient, it is easy to take so that the adherence of the patient is increasing, easy to procure for the national program. So these are all advantages of a fixed dose combination. And NACO has recommending dolutegravir as the first line regimen to be a component of the first line regimen since July 22. And the basic principle is that it is the first line for all treatment naive. Treatment naive means the patient has not experienced any ARV in the past. They are called as treatment naive. And the first line essentially comprises of an NRTI backbone. So when we talk of an NRTI or an NTRTI, it is basically we are talking of either tenofovir, zidovudine as some of the backbones, plus a lamivudine and one INSTI group. Now the INSTI group or the fusion inhibitors that we have is a dolutegravir. So you see here for everybody more than 10 years of age and weight more than 30 kgs, tenofovir 300 milligrams, lamivudine 300 milligrams and dolutegravir 50 milligrams regimen is given as a fixed dose in a single pill once a day. As per the patient's convenience, they can take the drug morning or evening. So this is the drug for first line management as per the national program. So there are certain other special alternate regimens that we need to see. For example, for PLHIV who is weighing less than 30 kgs, there we give 60 milligrams of abacavir, 600 milligrams of abacavir, lamivudine, and one tablet of dolutegravir 50 milligrams. And all patients with high serum creatinine value. So here this is based on creatinine clearance. Again, here we give a lamivudine as per creatinine clearance and the DTG 50 milligrams. So here we are actually not using tenofovir. So where we are not using T, there we will be substituting that with abacavir in the alternate first line. So whenever we say alternate first line, it is not failure. It is you are substituting that particular drug which is offending either because of a side effect or the patient is not able to tolerate it. Then we substitute just that one part. If the patient is weighing more than 30 kgs, actually the patient should be getting TLD, but here less than 30 kgs, so we are substituting that with abacavir. There's a logic here. Then with high serum creatinine, yes, we are again trying to substitute it with abacavir. Then PLHA1 rifampicin containing ATT regimen. So I already told you that we have to give an extra dose of 50 milligrams to be provided 12 hours after taking the regular dose until 2 weeks after completion of ATT. So even after completion of ATT, we need to give this extended for 2 weeks more. It is only because the rifampicin level stays in the blood for a longer period. So if you stop immediately after 6 months, what happens is the stasis of this rifampicin within the drug, the T half of that is T half of that drug is longer. So what it happens is for the first 2 weeks, if you don't give that additional dose, the current single dose that you're giving in the morning or evening, that becomes a subtherapeutic dose. So there's the reason we extend 2 weeks after giving, after completion of anti-TB treatment. And women with childbearing potential, yes, we all have heard about this in the previous session. I will not extend more on this. But now what you need to understand is the preference need to be given to the women of childbearing age. We need to give options, counseling need to be done, and then offered a regimen that is most selected, given the choice by the pregnant woman or the childbearing age. Now, there are many instances where we are seeing that suppose I go to an ART center and I ask the medical officer, sir or madam, why have you not started this patient on ART? So immediately what they say is, sir, the investigations are not available. They do not come back. We need to refer our patients for investigations. Yes. So in order to make patients' life easy or to actually comply with the evidence that we have on rapid ART initiation. So we have several literature available on the advantages of initiating ART on the same day or within a week of starting, within a week of diagnosis. So the advantages are that whenever you start a patient immediately on antiretroviral therapy, the survival is highest. Okay. Again, the OIs that you see are very lower. There's no much morbidity that the patient will be suffering. And you also see that there is a decrease in the loss to follow-up rates when the patient is immediately started with a full knowledge of antiretroviral therapy. So for our instances, NACO had now come up in these guidelines that you need to start antiretroviral therapy as soon as possible. And on day one, we need to assess the physical examination. And if you see in the box that has the physical examination, these are called as signs and serious illnesses that we need to rule out. That is a temperature, respiratory rate, heart rate. And if anything has a no from this or an yes from this, we need to further evaluate the patient. Otherwise, as you go through the algorithm at every step, if you are getting no, then the patient should be started on ART on the same day, preferably, or within 5 to 6 days. If you go through the guideline, what the guideline says is, if a patient is coming to you, if you are able to clinically screen well, physically look at, take a good history, rule out comorbidities, and then you send the blood for investigation, you can tell the patient to come back after 15 days to again re-verify the lab findings. So if there is nothing, everything is normal, you just need to record all those values in the white card and then the patient can be continued. So this is the advantage of using this algorithm. And in places where you are getting your investigations at you're taking time, that should not impede the patient. And for any SACs people, if somebody is on the call, what you need to understand is this is a very critical observation that has come out in most states, that if you do not start ART immediately, if you keep on shunting the patient for investigations, your priority loss to follow up in those days was very high. In the current circumstance, what you will have is people identified HIV positive but not initiated on ART even after reaching the ART center. If you are seeing a gap here, that means there is some problem in that particular center on in getting investigations and not starting ART, or they are just waiting for the investigations and not initiating patient on ART. So this is the operational relevance that SACS personnel can look into whenever you're looking the performances of each of your centers. Yeah, this I have explained in detail. You can go through and if you have any doubts. Now, once we start a patient on antiretroviral therapy, we know what to start now. So what to start is the first yes. Then when do you actually, how do you actually monitor the patient on antiretroviral therapy? So for each of the drugs, we have some fixed uh, investigations that need to be done at a period, for example, 3 months, 6 months, 1 year. So this is a frequency of investigations that we need to do in order to understand that the patient's antiretroviral therapy is functioning. And we also have to look at the CD4 and the viral load counts of the patients. So this is again is a table that is given as part of the national guidelines. So the body weight or the weight of the patient should be measured during every visit. In the section 13 of the white card, this is one part that usually is missed. And the importance of this is mainly in children. You see that there is a change in the weight band, and whenever there is a change in the weight band, if you do not change the dosing of that, the child will get a subtherapeutic dose if you do not monitor the weight. So this is very, very, very important. And treatment adherence, the pill count that we will be seeing at the end of this session, and clinical staging or T staging that we do. Four symptom screening is again that we do for every patient during every follow-up visit to the ART. Then now we talk of screening for common non-communicable disease like hypertension, diabetes every 6 months, or symptom-driven lab evaluation based on ART 6 months, CD4 every 6 months, and viral load. So there are some exceptions for viral load and for CD4 in terms of if somebody has a suppressed viral load, then you can stop doing the CD4 count. And when again to restart, these are some of the things that you need to understand. So the clinical monitoring of the patient you do during every visit. And whenever we say clinical monitoring, please remember that is a good system review. We need to ask the patient on the side effect and also monitor the weight of the patient. And as a medical officer, our duty is also to understand whether the patient is taking pills, and the pill count starts from every desk within the ART center, and look for something called as an IRIS, immune reconstitution inflammatory syndrome, right? Virological monitoring, usually the first 6 months we do it. That is, today I start ART. At the end of sixth month, I get a viral load. This is all for patients who have started ART newly. Or if there is a documented switch or a substitution, then we do at 6 months immediately after starting substitution switching. So the 3 S you remember. So at all these three in all these three situations, we do a repeat viral load or a next viral load. For a new patient, it is going to be a 6 months. Then for a new patient, again at 12th month, thereafter, every year we do a viral load. And less than 1,000, we continue the same regimen. More than 1,000, we do a step-up counseling, repeat it after at least 3 step-up counseling sessions. And then if there is an increase in the viral load, then we go for a ESASAP, and then we go for a substitution for a switch if required. So this is the sequence of events, and there is no much change in the guideline. This we keep following. So we need to do, for all patients, we need to do a CD4 HP total lymphocyte and a differential leukocyte count, and then SGPT and serum creatinine once in every 6 months. So that is the top line needs to be followed for every 6 months we are doing. And monitoring patients on ART follow-up, if you are on a tenofovir-based regimen, serum creatinine, we need to do it for every 6 months. Urine for protein every 6 months. Then again, zidovudine-based regimen, you know that we need to do a complete blood picture for every first month, third month, 6 months, and then 6 months every time. So this is the sequence of events. Specifically, I want you to take your observation to dolutegravir containing ART. You need to do a blood sugar and an SGPT at baseline, 6th month. Then every 6 months, we need to get the blood sugars done. So now this is very important. There is a change in the definition for adults and adolescents compared to the previous guideline. So if a patient who either an adult or an adolescent should be termed as stable if they fulfill all these criteria on ART for at least 6 months, no adverse effect requiring a regular monitoring, no current illness or OI or a medical condition, and a suppressed viral load. So these are all very important things that we need to have while we define somebody as a stable patient. Taking this definition, either the patient can, because the patient is stable, you can either put them onto a link ART or a decentralized site or in a carg model, or you put them on MMD. So this becomes the central fulcrum to identify whether who are those patients who could be going for a decentralized dispensation or a carg model, or what's our is the differentiated care models that we are thinking about. Now, this is a phenomenon that we see. This is called as IRIS, is immune reconstitution inflammatory syndrome. This is also called as known as a paradoxical reaction. So this is not just limited to HIV drugs, but it is also seen in TB treatment at the initial stage. So what an immune reconstitution inflammatory syndrome simply means simply what it is to a layman. I, I start taking ART and I'm getting worse. Now, why I'm getting worse is because there is some immunogenicity that is developing within my body. Because of that, my immune system is hyperactivated or it is very well activated. So my memory cells start acting. So what all infections I had previously, or an occult infection, what I have, or a subclinical infection that I'm having is getting up into a full-blown infection now. So that is the meaning of a paradoxical reaction or an immune reconstitution syndrome. So you may get certain infections. Common things are like TB, cryptococcal meningitis. These are some of the common immune reconstitution inflammatory syndromes that we see. And usually this happens at the initial stage when you start ART, that is within 6 months of starting ART, there is a chance of getting immune reconstitution. And there is an increased CD4 happens at that point, because the immune cells, whatever are in our body, are nothing but CD4 again is one type of an inflammatory or an immune reconstitution cell that we have, or cells, inflammatory cells that we have within the body, which tend to increase from the baseline that we had. So having an immune response is a positive signal. That means the drug is working. There is some inflammation and then immunity system is awakened and system is acting. So, I mean, the patient will have worsening symptoms, but for a clinician, what we need to remember is that the drug that you are giving actually has started or initiated the immune system to start functioning. So that's a good sign from the physician point of view. Yes, if there is an infection that you are seeing, for example, if a patient now is getting a TB now, a frank TB after initiating treatment, yes, we also need to start treatment to treat the tuberculosis or crypto, herpes, whatever is the infection that the patient is coming with. And this usually you see in the first 6 months. At that point of time, the evidence that we have is a rapid increase in the CD4 count. And who are those patients who are more prone to IRIS? Are patients where you start with a very low CD4. Suppose if the baseline CD4 count is less than 100, in those patients, there is a higher chance of getting iris. Then with a rapid initial fall in viral load due to therapy, then you see among males, among younger patients. So these are all some of the factors where we have seen an increased chances of getting immune reconstitution syndrome. So I'm not go more in that because you don't actually see this in the practice, more of theoretical component. Yes. So management, actually, what you need to do is whatever is the infection that you are getting, we need to treat that. And you also need to identify, to ensure that you do not stop ART just because there is an IRIS. You should not stop any antiretroviral therapy. So that is one thing you need to remember. Now, after knowing how to monitor ART, if there is an IRIS, what should I be doing? Then after knowing which drug that you should be starting, what are the different classes of drugs? The very important thing that we need to understand is the success of antiretroviral therapy does not depend on which regimen you are, but it exclusively depends on how the patient is taking ART. This is important. That's why we say in the initial initiation time, patient should be understanding that the ART is lifelong and it should be taken irrespective of any function, family, friend, death, or anything within the family. And it should be taken even if there are other concomitant comorbidities that are coming up over time. So this is the level of discipline antiretroviral therapy requires. And that should be given from the ART center, from the counselors, and all the ART staff as a team should be able to support the patient to understand at every visit that ART is important, adherence is the key for success of antiretroviral therapy. So these are the definitions between what is adherence, and for us, what we talk to the patient or how we counsel the patient, what they need to understand is that if you are adherent to antiretroviral therapy, the replication of the virus is going to decrease. And if the viral replication decreases, chances of getting OS is also going away. And there are several studies done in the past to understand how does adherence and the level of the drug or the viral replication behaves. For example, uh, if you have 100% adherence, your viral suppression rates you have around 98 to 99%. And the more you lose adherence, you have a twofold or a threefold increase in the viral load or a viral rebound happens. So if the patient is not LFU, not a miss case, but I'm missing the drugs in between even in that month, that is also very dangerous because this on and off of the drug that we have, okay, you're not giving the drug pressure to that virus. So what happens now? You remove that pressure, there is a rebound of viral replication happening. Whenever a rebound viral replication happens, there are more and more chances that there is a mutant variations come in. So at that point of time, to develop resistance and also or to get other opportunistic infections is very high. So don't have in your mind that that's okay, this patient is coming regularly, but only in between he is missing 4 to 5. So cumulatively, if you start that he is as good as missing an extended period of antiretroviral therapy. So that's why we say a minimum of more than 95% of adherence is required. Now, there's a small fine line between compliance and adherence. Compliance is patient's behavior matches with the prescribed advice. But the only thing what we are looking at here is not just the obedience or that, but it is actually taking the drug is what is important to us. Now, some of the things that we need to tell in specific populations related to adherence of antiretroviral therapy. One very important is pregnancy and postpartum women. We need to say that yes, we have nausea and vomiting that will negatively have on treatment adherence, but this is what we need to specify and tell them that if it is not in the morning, you can take the drug in the evening. So these are some of the alternatives that we need to give to pregnant women or postpartum women. And also, if there are concern about pill burden, then we reduce some of the pills. For example, you're giving both cotrimoxazole, you're giving IPT, you're giving everything. So you can reduce some of them which are not most essential at that point of time. Next, adolescent. Adolescent is one very important group. Here we actually need to identify treatment buddies or what we call them as treatment supporters, even within the family members, and be very um, engaging them during every visit in terms of giving them them importance on adverse effects, inconsistent daily routines, not remembering to take medication. These are some of the risk, or these are some of the things that usually an adolescent has, and they are at an experimenting age. So more and more we need to keep on reinforcing the message. Um, yes. So counseling, the newer guidelines, what we have is counseling for preparation and adherence. We have almost around 6 steps of counseling, preparation and adherence preparation. So please look into these things. So step 1. And then 2, counseling more than one individual, how to do. Step 3, solving problems. So these are all, and we also have a checklist. And I hope everybody knows to calculate adherence. That is actually how many you have given and the number of days. And that must be equal to number of pills given to the client, number of pills in balance by the client that should have taken. So this is how we do a pill count. Uh, these are some of the examples. Yeah. And to end this session, to give a summary of today's session, we have started with why is it important to start ART. We have seen goals. We have seen the principles, how ART is given in the form of different groups. Then we saw group-specific toxicities. We saw drug-specific toxicities. Then we have seen drug-drug interactions. After that, we have seen who should be given ART, how the ART program has evolved from less than 200 to the current treat all policy, why DTG is the mainstay. Then we have seen alternative regimens for TLD, where we have seen creatinine clearance higher. We have seen where TB patient is, whether the patient has a weight less than 30 kgs, and what should be given. Then finally, we have seen adherence and how to monitor the patient during every visit. So the next session, I think we have on 9th of Jan, mainly on advanced disease management. So
Thank you so
Thank
much,
you.
sir. Keep one highlight and what is to take.
Thank you, sir. So participants, in case you have any questions, please, you can unmute yourself and you can ask.
Hello, sir.
yep, yes, ma'am.
Sir, you said that when the weight is less than 30 kg,
Mm.
you give Abgavir based on weight band, no, not 600 mg. No? Suppose
Abacavir?
the patient's weight is 25 kg, then it's supposed to be given on
Yes,
weight
yes,
band, no?
yes, yes, yes. Yeah, good, good. Thank you, ma'am.
And one more thing I wanted to. So when the adherence is calculated and there are two drugs, suppose there is Abgavir and atazanavir, ritonavir. So the adherence for each drug will be different. It will be different for AL and it will be different for ATR. Which is supposed
Yeah,
to
so
be?
we'll have to calculate both and see.
So both we have to mention.
Yes, ma'am. Yes, yes.
Sir, good afternoon.
Yes,
Sir, I
ma'am.
have a question, sir. By chance, if CD4 count is less than 350 and a person is allergic to sulfur drugs, what alternative can be given, sir?
For cotrimoxazole, right?
Yes, sir. See, if person is allergic to
Dapsone.
sulfur drugs. Yes, sir. So cotrimoxazole cannot be given. Then,
Yeah.
sir?
Alternatively, dapsone is recommended.
Okay, sir. Sir, at a
Dapsone
dose
is
of
the drug that is. Yeah,
Oh.
yeah. Sorry, I cannot remember the dose, but it is in the guideline. Dapsone.
Sir, will it
is
be given
already-
by the this provided by NACO, sir? If we request for?
I think more of drug procurement, everything is decentralized at SACS level. So, and
Okay, sir.
if there is a specific patient in those terms, possibly if you're getting dapsone in the leprosy program, if you have it, that's okay. Or I think we'll have to get it through the hospital purchase itself.
Okay. Okay, sir. So that's okay, sir.
Excuse me, sir.
Yes, yes, ma'am.
So in case of TB and ART, TB and HIV, we start ATT first and then ART, or we can start both simultaneously?
I mean, see, it again, what we are saying is for a patient who has a CD4 count less than 50, you're talking
yes,
about
sir,
that.
that's
We
also
say
right.
concomitantly, you start both ART and ATT.
Yes,
Don't worry about the immune reconstitution syndrome in that particular case. But if you really want to rule out if there are any adverse events occurring to a TB drug, and is it because of TB drug or ART? So in order to give that space to the clinician, we say that it is better first to start ATT and then you start ART within 2 weeks. But don't go like previously we were saying take 2 months and all. Okay. So now the guideline is within 2 weeks you try to initiate the patient on both ATT and ART, but start ATT first to
Okay, sir.
understand if there are any side effects. Yeah.
Okay. So, and in case of ANC cases, the new guideline says that it is compulsory to do viral at 32 to 36 weeks.
Yes.
But some
So
people come at third trimester. So,
exactly. So what to do, sir? Yeah. So if you look at those guidelines, mainly why we are telling you to get that viral load in that time is to determine which type of prophylaxis that the exposed child should be getting. Whether it is a dual prophylaxis or a monoprophylaxis, what should the child get? So in case you have a viral load and the viral load is less than 1000, then there is no need of a dual prophylaxis. Okay.
so we
And
have to
suppose your example of a patient coming in labor, or they did not have a viral load, or if the viral load report is not available, or if the viral load is more than 1000, then you should be giving the child straight away a dual prophylaxis.
Okay, thank you.
Yeah, this is the implication of that.
So there is one question in the chat box.
Okay.
Second line treatment patient with unsuppressed PVL should be sent to SASEP, or can we start EAC at MO level?
See, you better do an EAC. Okay, so for the first viral load that you are getting, even if a patient is on second line, and then you get a high viral load, do a EAC at your level, and then only refer the patient. That is, you are convinced that the patient increased viral load is not because of failure of adherence, but it is the failure of the drug. With that notion, you are referring the patient to SASIP. But if you are not convinced, that then you cannot refer. Okay, so you are referring it only after you rule out that adherence is not the issue for the increased viral load. So bottom line is you need to do EAC, do a repeat viral load, and then refer to the SASIP.
So there is one more question. If the mother is on ART and the child is on nevirapine, can she give breastfeeding to the child?
The mother is on ART, and yeah. So if you see our guideline again in the PPDCT chapter, so what we are again promoting is an exclusive breastfeeding, not a mixed feed. So if you are on exclusive breastfeeding, yes, we are promoting it. Even if the mother is on ART, we still advocate for it. But if you are able to rule out the AFASS, that is affordability, feasibility, it is safe and all that, AFASS is the mnemonic that we use. If you are able to rule out that, and if the mother is willing for a replacement feeding, that is very good in terms of viral transmission to the mother to child from breast milk. So the option is again given to the mother, and once the option is taken up by the mother, the guidance that we need to look, or what we have to be ruling out, is whether the mother is whether the breast milk can be the alternate feed can be affordable, okay, feasible, safe, sustainable. So these are all FAS is the principle that we use. Once that is ruled out, if you're looking in terms of HIV, that is the best thing. But in terms of other diarrheal diseases, in the context that we are in the developing nations, what we need to do is child is dying more of diarrhea rather than HIV. So we usually, the national program recommends exclusive breastfeeding. And if the mother is on ART, and if it is the viral load is suppressed, I don't see again transmission chances to the exposed child.
If the mother is not willing to breastfeed, what are the drugs that we can suggest?
Not willing to breastfeed, you don't have any regimens based on mother is breastfeeding or not. The only regimen that the best regimen for the mother to be on is dolutegravir in the current circumstance. That should be given. So if the mother is again on any other regimen like an NNRTI based because of any operational reasons or something, we need to put the mother on dolutegravir based regimen. That is the best. So the regimen doesn't change based on the option of breast milk or not. The ART backbone doesn't change.
So another question, as soon as possible means in TB treatment on the next day of TB diagnosis, can we initiate ATT on the same day?
Yeah, this is mainly if the CD4 count is less than 50 cells. That is the recommendation. We will anyhow see it, but you can go back and just review. We have a table in the chapter of TB co-infection. There we have given underlined and told that yes, you have a risk of iris, but you can start immediately in this patient, usually with a lower CD4 count.
So there are no more questions. So thank you very much, sir. Thanks to all the participants. So participants, you are requested to kindly enter the e-poll, which will be displayed on the screen shortly. And just one request to all the SMOs and MOs of the ART centers to kindly attend the post test also. The link will be shared soon on the email with everyone. So there is one last question also. As it is advised to initiate EAC for viral load unsuppressed cases, the Dr. Hima needs a clarity on that.
Okay. Yeah, Dr. Himabindu garu. So EAC, as it is advised to initiate EAC for viral load unsuppressed cases, need a clarity. Yeah. Viral load unsuppressed. So when I'm saying viral unsuppressed, that means the viral load is greater than 1000. So if somebody's viral load is greater than 1000, today I have sent for a viral load and the result has come back that the patient's viral load is greater than 1000. So as a clinician, what you have to understand is whether this increase in viral load is because the drug is not able to act on the virus, or is it because of the patient is not taking the drugs? That's why the viral load is high. So there is a big difference between these two decisions that you need to take. So to help you with this decision, what you have to ensure is you have to ask the patient clearly on adherence in this last 6 months. If there is a problem, you want to set that right in the next 3 months. And after setting the adherence, if you're convinced now that now his adherence is good, you do a repeat viral load in that patient. So that 3 or 4 months of period that you're monitoring the adherence is nothing but enhanced adherence counseling. After that, you're doing a viral load. That viral load will, if it is high, that means the patient is adherent, but the drug is not acting. That is the meaning if you are getting a repeat viral load higher. The second thing is if you're getting a lower viral load, that means you're able to counsel him better. Adherence is there now, and if adherence is there, that is the reason why he had why he had a higher a viral load earlier. It's not because the drug is not acting. So this is the meaning of enhanced adherence counseling after an unsuppressed viral load. Hope it's clear now, Dr. Hemabindu. Now coming to IPT prophylaxis will start immediately after 3 months or after 3 months. Yeah. So the current guidelines, again, if you see, Dr. Ramya, we have told you that it can be concomitantly given with antiretroviral therapy. Concomitantly means along with ART. On the same day, whenever you are starting ART, you can also start IPT. And the only thing is, we have seen that, I mean, if you look at the literature, what it says is concomitantly, if you give both ART and IPT together, there is more immunogenicity that happens. And so there is more and more prevention, or the cell mediated immunity can be enhanced, because if you're giving both of them concomitantly. Yeah.
Thank you, sir. Thank you to all the participants.